Hello and welcome to this edition of Mini Gem for the Association of Elderly Medicine Education. My name is Sabiha Ali and I am going to be talking to you today about assessing the elderly patient with back pain. So let's get started. By the end of this mini gem, you will be able to assess the elderly patient with back pain confidently, be able to understand the basic pathophysiology behind the aging backbone, list the common causes of mechanical and non-mechanical back pain, and also know the importance of pain management in the elderly patient. Back pain makes up 5% of all medical consultations in the UK. The prevalence of back pain in the elderly is as high as 70%. In the elderly population, the more sinister causes may often not be distinguished from benign causes, leading to misdiagnosis, morbidity, and even mortality. Elderly patients often present atypically to the emergency department. They may be off legs with a history of reduced mobility or an increase in falls recently. It is important to ascertain the duration of symptoms and assess for acute confusion and delirium. A full drug history will reveal analgesic use, and the patient should be assessed for constipation. More often we rely upon carers and relatives for collateral history to assess a patient's functional baseline. On examining these patients, do take note of bedside clues, such as inspection for cachexia, posture, and whether the patient is in acute pain. Also look around the bed to see if there's any walking aids. A full musculoskeletal exam will be of great value here to examine joints above and below for referred pain. Do palpate along the whole length of the spine to see if there are multiple levels that are affected. And a full neurological examination is important to look for signs of cord compression. Then proceed on to a rectal examination and abdominal examination to assess for bowel and bladder function. And lastly, assess the patient for any signs of Paget's disease, signs of heart failure, bony deformities, and deafness. It is vital to assess these patients for red flags. So if they're over the age of 50, acute onset of lower back pain, any presence of neurological signs, bladder and bowel involvement, which is usually a late presentation, previous histories of cancer and family history of cancer, and systemic symptoms such as weight loss. So my top 4 tests for investigating elderly patients with back pain include blood tests, looking at an ALP, calcium, PSA and inflammatory markers, x-rays to assess for degenerative changes and fractures, a whole spine MRI to assess for cord compression, and a myeloma screen. In the aging backbone, it is important to understand that degenerative changes themselves do not cause pain. So where does the pain come from? Breakdown of the discs and wear and tear of articular cartilage may contribute to nerve root impingement. Also, development of osteophytes has a role to play in this, including compression fractures themselves causing pain. A significant proportion of patients presenting to the emergency department with acute back pain will have a mechanical cause, likely musculoskeletal in nature. Often these symptoms are exacerbated by movement, particularly bending or stretching, and are relieved by rest. A common diagnosis made in the emergency department is sciatica, irritation of the sciatic nerve, presenting with acute pain shooting down from the lower back into one limb. The mainstay of treatment for these patients is good analgesia and onward referral for physiotherapy. A proportion of these patients may go on to have further investigation and extensive imaging done, which may reveal spinal stenosis. This is important as in extremis this has a high risk of cord compression. And therefore some of these patients will be assessed as to whether they are suitable candidates for surgical decompression. Fragility fractures are more common in our female elderly patients with osteoporosis. These patients will be found to have wedge compression fractures on x-rays. The pain is the main symptom to be treated here in order to prevent further complications such as delirium, in-hospital chest infections, PEs and DVTs from further immobility. A stepwise approach to the analgesic ladder should be applied here. However, these patients respond quite well to opiates, particularly patches. Consideration of IV bisphosphonate is important, and if this is not tolerated or contraindicated, then denosumab. Additionally, if pain is poorly controlled and the patient is thought to be an appropriate candidate, they should be referred on to their local spinal team for percutaneous balloon kyphoplasty. The diagnosis of acute spinal cord compression will get the attention of any clinician. The patients present primarily with initial symptoms of pain, and then motor and sensory symptoms, and lastly bowel and bladder dysfunction. These patients need urgent investigation with MRI of the whole spine, followed by urgent referral to the local neurosurgical unit. Acute spinal cord compression is commonly due to metastatic disease, and 60% of patients with a diagnosis of multiple myeloma will have skeletal lytic lesions on presentation. These patients will either go on to have surgical decompression or radiotherapy. Here is a recap of the learning outcomes. I hope you found this mini gem useful, and thank you for listening.